the invitation to come speak. What a great conference. Some of the best people in the world have gathered here. I'm going to share with you today more of a practical approach from the perspective of a clinician. But let me begin with just a few slides. But we really, at Bateman-Horne Center, we do some clinical trials, but we will not be discussing them in today's presentation. And I'm not going to tell you too much more about Bateman-Horne Center, but we are a nonprofit organization that does clinical care research and educational resources, specifically for people with ME/CFS, fibro, long COVID, and related comorbid conditions. And I'm hoping by the time I finish, you will recognize the presentation of long COVID and post-viral syndromes, identify common comorbidities, and design simple treatment plans for individuals with long COVID and related comorbidities, specifically through the lens of ME/CFS. So we know that SARS-CoV-2 can impact almost every organ system. And this has been our journey in medicine to understand more about acute COVID. And now we're really trying to understand long COVID. And there are really two main groups of post-COVID conditions. The people who had severe infection, often hospitalization, organ damage, and a lot of objective markers. But there's a growing number of people with mild to moderate infection initially, but lack of recovery or even increasingly worse symptoms and impairment, yet without apparent biological markers. And this group can easily be overlooked and more confusing. Because there's so many names and definitions of post-COVID conditions, I'm going to use the term long COVID, and I also want to talk primarily about group 2 today in my talk. What causes long COVID? That much is still unclear, and I think you'll hear a lot more about causes and physiologic manifestations in the conference today. And so I'm not going to delve into too much what the causes are, because we already know many things about post-viral syndromes and comorbid conditions, but especially from studying ME/CFS. And ME/CFS, in case you're not familiar with it, is myalgic encephalomyelitis. And in the US, we often combine the old-fashioned term chronic fatigue syndrome with the term ME, or myalgic encephalomyelitis. From what we know about this illness, it's a chronic, complex, debilitating multi-system illness that involves the brain, the peripheral nervous system, the immune system, the circulatory system, and there appears to be impaired cellular metabolism. Now, this illness manifestation is often a post-viral or post-infectious syndrome, but diagnosis is typically made late or ever, and thus the evidence of the acute infection gets lost. And diagnostic studies of common potential pathogens were not always done at illness onset. And immune triggers can also be associated with the onset of ME/CFS. So this is challenging for clinicians. We know historically that ME/CFS specifically can be triggered by a variety of pathogens, certain viruses, and I've listed a number of viruses here that can be culprits, including earlier coronaviruses, SARS-CoV-1 and the MERS virus, before we have our acute COVID-19 outbreak. But post-infectious syndromes have also been documented after Giardia, Q fever, Lyme disease, and others. And like I said, ME/CFS is frequently diagnosed very late in illness, or never diagnosed, or misdiagnosed. But we know that people with ME/CFS, although it's a heterogeneous condition, share the same core or common symptoms, likely due, but the heterogeneity may be due to the systems affected, how long they've been ill, the development of comorbid conditions. And it's been challenging to study. But with long COVID, we have the opportunity to look at illness in the first stages of illness, and when we have a much better idea of what the pathogen was that triggered it. So let me teach you about the US National Academy of Medicine ME/CFS clinical diagnostic criteria. They're mostly used within the US, and there are other criteria for ME/CFS or for ME, but these have proven to be really clinically useful criteria for physicians. So in order to make a diagnosis, a patient should have these core first 4 to 5 symptoms. They need to all be present, and they must be moderate to severe and frequent, which is defined as present greater than 50% of the time. That is impairment of normal function, accompanied by fatigue, at least 6 months in duration. Post-exertional malaise, which I'll talk about a little more. And those two are very, very important. Then sleep, unrefreshing sleep or problems with sleep, and at least one of the following: cognitive impairment or orthostatic intolerance. Those are the core symptoms that need to be all there, moderate to severe and frequent, these are the shared characteristics of people with this illness complex. We know there are other features that are a little more not as universally present. Those are chronic pain conditions, immune and inflammatory manifestations, infection manifestations, and what have been called neuroendocrine manifestations. These are common and can be really problematic in patients, but are less consistent across the whole patient population. We distinguish ME/CFS from other post-viral syndromes by the amount of impairment or debilitation and the development of post-exertional malaise. So post-exertional malaise is illness relapse or symptom worsening triggered by activity or stressors. And these stressors can be physical, cognitive, sensory, emotional, or even being in the upright posture. PEM and impaired function occurs in many patients with long COVID as well, and many of those patients meet ME/CFS criteria. And at least in the ME/CFS patient population, illness severity and functional capacity ranges from mild impairment but difficulty maintaining a normal schedule of life and low tolerance for exercise to bedridden, barely able to speak or move. And we call those patients the severely ill or the very severely ill. There are important comorbid conditions to consider in long COVID and ME/CFS beyond the objective organ damage. This is a list of those comorbid conditions, and I'm going to focus more on the ones in the box, but cognitive impairment, orthostatic intolerance, mast cell activation, small fiber neuropathy, which is damage to the tiny small nerves that are involved in sensory perception and the function of the autonomic nervous system. There are many disorders of sleep and disturbances of sleep, as well as primary sleep disorders. There may be upper and lower gastrointestinal symptoms and dysbiosis. But for sure, in my opinion, and in the opinion of most people who study post-viral syndromes and ME/CFS, if the symptoms in long COVID persisted 6 months and meet established criteria, you should make a diagnosis of ME/CFS. It could be post-COVID or post-SARS ME/CFS. So let me just give you a very practical approach from a clinician who has taken care of ME/CFS patients for a few decades now, and add some of the insights that I have gained in the last 5 years taking care of ME/CFS, but also in seeing long COVID patients. So this is my approach, and I'll give you a little visual of it in a minute. It's a pretty simple formula. And this is in the absence of targeted treatments that are going to cure the disease. So first of all clinicians should be able to do this. So first of all, identify and treat all medical conditions that you can see as part of the presentation. Second, and probably primary for the illness, is learn to pace activity. That means reduce the severity and duration of post-exertional malaise by reducing the duration and the intensity of all activities that might trigger post-exertional malaise, and teach the patient to do this so their symptom burden comes down. Next is to address the major symptoms of the illness. And on top are sleep, pain, mental wellness, and a little bit about fitness, but only if it doesn't cause post-exertional malaise or worsening of illness. And then I want to talk about targeting 2 of those common comorbid conditions, because these are the ones that are the most often missed. and yet they can respond to supportive treatment. And here's my diagram of this that I've used for many years. So up in the top left corner is you've got to pace your activity to avoid worsening of illness, pain amplification, worsening sleep, a crash, and worse energy. And so the three table legs are in front of those major symptom categories, and those determine the stability of the table and the functional well-being, which is on top. And in smaller print in the back, and the leg you can't see, is fitness, because fitness is only achievable to a degree depending on the severity of illness. Well, now we know that there are at least two other comorbid conditions that are overlooked, but are commonly present, and even more commonly in long COVID than what we've identified in long-standing ME/CFS patients. So how can you learn from your patients their level of impairment? Impairment function is quite difficult to communicate. It's hard to measure. So I'm just going to give you two easy things to remember that we use in clinic that really speed up the ability to estimate people's function. And the first is to determine the patient's hours of upright activity. And this, we're defining for this purpose, that's the total number of hours with your feet on the floor in 24 hours. Now that includes sitting in a chair with your feet on the floor, that's upright, standing and walking. Probably includes driving, sitting. So it's all the hours where you're not lying in bed or having your feet elevated. And normal people have, generally 14 to 17 hours per day of hours of upright activity. Lots of people with chronic illness, including chronic pain conditions and other chronic illnesses, still have 10 to 12 hours of upright activity tolerance because they rest in sitting position. But people with ME/CFS, orthostatic intolerance, and POTS and similar conditions often will report 0 to 8 hours of upright activity tolerance. And even people that are really quite functional with ME/CFS might report 8 hours of upright activity tolerance, and that is not quite enough to maintain a full-time employment. So they often, if they're able to work, they do it by building in rest periods or work from home and other things to be able to do it. Of course, you have to rule out severe depression as a cause why people just want to stay in bed and pull the covers over their head. So remember this, how we define this. And the other we use is a simple, what we call the good day, bad day questionnaire. And I actually have people just fill this out on a computer, or we used to do it on paper. And that is, I have the patient, this is spontaneous answer from the patient, to give us the average number of good days and bad days per month. Just divide them up. Like, I have 10 good days and 20 bad days per month on average. And then I ask them to estimate their average hours of upright activity on a good day and on a bad day, using that same definition we just talked about. And then I have them give examples of tasks or activities they can do on a good day and can do still on a bad day, and give examples of activities or tasks that you cannot do even on a good day, and you for sure cannot do on a bad day. And I don't coach people very much about how to fill this out. They write it, and then I look at it, and it gives me an immediate picture of how impaired they are. And also if they're having push crash cycles, if they have, but it also helps me understand kind of their window of function of what they can do and can't do. And it's usually very, very helpful and educational for understanding right away a person's function. So let's talk about some of these comorbid conditions. And let's start with orthostatic intolerance. And what is orthostatic intolerance? So this is the definition. Orthostatic intolerance is the development of symptoms in upright posture that are relieved or improved by reclining. It's actually a symptom, and it's an observation. there are ways, and if you need to ask people about this, they need to help them understand what you're asking. But once they understand what you're asking, and this is part of hours of upright activity, right? And ask them if their symptoms are better if they lie down and get worse the longer they're up. And you can have a lot of different symptoms from orthostatic intolerance. So there are ways to objectively measure syndromes of orthostatic intolerance. And we have names for them, orthostatic hypotension and POTS, and we'll talk about that in a minute. But we've tried to use a standardized 10-minute passive stand test that we've dubbed the Nasaline test. And the way to do this test in the office is to record heart rate and blood pressure after 10 minutes of supine rest. So get the patient really relaxed on a table near a place where they can stand in a few minutes, and take the blood pressure and heart rate a couple of times while they're lying down. Then have them move to a standing position. We use the passive stand test, which means you lean against the wall. We think it's safer for patients in case they feel more confident that they're not going to fall down. There's lots of debate about whether to use a passive or an active stand test. But once they're in that standing position, use a pulse ox and a blood pressure cuff and record the heart rate and blood pressure every 1 to 2 minutes. It's trickier to do it every minute. I like to do it every minute, but you can do it every 2 minutes for at least 10 minutes, unless the patient cannot stand any longer due to feeling lightheaded. Then you have the opportunity to interpret this test. So let me show you one example. This is a real patient who came in. He was age 45 when we first saw him. He'd been sick since COVID for 7 months. He did not have a diagnosis of when he came to see us. We did this. You can see the lean test here. So here are his 2 supine blood pressures at the top. Couple 115/75. His heart rate was in the mid 60s. And then after he'd been there for 10 minutes and rested, we have him stand up and lean against the wall. You can see that his blood pressure stays pretty good, but his heart rate immediately jumps and keeps climbing and climbing. It was 103, 115, and around 7 minutes it was 120, and then right when he was about to faint, it got to be 138. And you may not be able to read this over here, but he was very symptomatic. We terminated the test early and laid him down so that we didn't induce syncope in him. So this is a pretty extreme but real example of someone who developed postural orthostatic tachycardia syndrome, which is defined by a heart rate increase of at least 30 beats per minute in the standing position, or a heart rate that goes above 120. This is another patient. She was in another state and was contacting me for advice, and I asked her to arrange to have someone and do a 10-minute Nasaline test in her home. And this is what she sent to me. So her supine blood pressure was 124/68. And as soon as she stood up, you can see her blood pressure dropped tremendously, all the way down to 80/64 at 8 minutes. And she was actually did not feel syncopal or like she was going to faint, but it did reproduce her symptoms. You can see that her heart rate went up, but not to the extent that you see in POTS. And I also wanted to point out that you can use the pulse pressure to estimate what's happening with cardiac output as a sort of a surrogate. And you can see her pulse pressure, which is the systolic pressure minus the diastolic pressure, was 56, which is pretty typical. So the difference between 124 and 68. And at that time, she was about to faint. Her pulse pressure, or that, she was getting symptomatic. Her pulse pressure was 16, which is quite low. And there's actually a formula on the bottom. If you calculate the pulse pressure over the systolic pressure, it should be more than 25%. And hers was 20, which really suggests poor perfusion in this case. But she met the criteria for systolic orthostatic hypotension because her blood pressure dropped more than 20 points in the first 3 minutes, her systolic blood pressure. So knowing this is really important because, and this is a real healthy 70-year-old woman, we were able to, in the box, teach her about pacing and about awareness of body position, increase her fluids. We gave her primary care, gave her something for sleep and a little bit of sertraline for her anxiety. And she really did quite well. And it didn't take much, but it really improved her ability to function, to give her these tools. So very quickly, I don't have time to do a whole lecture on orthostatic intolerance, but it's pretty straightforward. If you recognize the common exacerbating factors, heat, dehydration, being up too long, muscle atrophy, even laying in bed too long can worsen it. There are some medications that might be making it worse. And if you're in post-exertional malaise, it can get worse as well. You can increase volume in the blood vessels with water or medications like fludrocortisone, and IV fluids can be very good at rescue when people are sick or not doing well. You can externally compress or internally constrict blood vessels. So compression, socks, pants, abdominal binder, and midodrine is a drug that is a peripheral alpha-1 receptor agonist that acts like compression. Other interventions for orthostatic intolerance include controlling the rapid heart rate response, if it's indicated and helpful, and strengthening the muscular pumps in the legs, or altering autonomic nervous system function with a drug that is used not as frequently, but pyridostigmine, which can improve blood flow in the legs and has other functions as well. So there's a lot of information out there about how to treat orthostatic intolerance syndromes, especially in the POTS literature. So I would send you there. So what about mast cell activation? What is that? Mast cells, just a little background, are white blood cells in connective tissues all over the body: skin, blood vessels, lymph, nerves, lungs, GI tract, all the places where your tissues interface with the outside world. And when activated, mast cells release inflammatory chemicals. That's part of their job. And when they are activated, they send distress signals through the nervous system, the immune system, and do a lot of signaling with all kinds of cells. So many people are familiar with more genetic variety of what we call mastocytosis, and we're really not talking about that right now, genetic or tumor related. We're talking about just activation, mast cell mediator, excessive mast cell mediator release. And an extreme example of this is anaphylaxis. So the criteria for mast cell activation, and you can look these up too, are really episodic symptoms in 2 or more organ systems: skin, gastrointestinal, cardiovascular, respiratory, nasoocular. Improved symptoms with things that calm mast cells, like H1 and H2, or histamine 1 and histamine 2 receptor antagonists, leukotriene antagonists, mast cell stabilizers, and other supplements, and even anti-IgE biologics if they're available. The third set of criteria are elevation, if you can find objective markers of these inflammatory molecules in the blood or in the urine. And if you find them, that's great. But sometimes, especially when symptoms are episodic, it's difficult. So if you have a clinical suspicion of mast cell, you can try mast cell interventions to see if it's going to help symptoms. So just to remind you, I'm hoping that you'll be able to recognize the presentation of long COVID and post-viral syndromes, especially ME/CFS, identify common comorbidities, especially the ones that we don't talk about often enough, and design simple treatment plans for people with long COVID and related comorbidities, especially having a new recognition of ME/CFS. So I think there are some questions.
Hi, yes, excellent presentation. We've got several really great questions from the chat. The first received from a Portuguese internal medicine physician who has begun to see several patients with ME/CFS and ME as a result of long COVID. The question: We desperately need more clinical training and information in Portugal. What opportunities are there for further health professional education exchanges on ME/CFS, long COVID, and related disorders? And the second question pairs really well. It's received from a medical student about to graduate, asking for resources and how to incorporate this teaching into the medical school curriculum.
Those are really great questions, and I think we're all over the world trying to understand how to get more information in professional education, and out in the trenches, in the field, and for medical students. I left my slide up a little bit longer because at the Bateman-Horne Center, we've been working hard to figure out how to get medical education out there. And we have a lot of resources on our website if you can reach it from Portugal. And there's information there for patients and a lot of information for medical providers as well. I also wanted to point out that there's something called Project Echo in the United States. And this is an online case-based lecture series. And I put up 3 of these echoes that are available specifically for long COVID. And the last one is one that we've been involved with, the utah.edu echo long COVID. And if you can figure out how to go to these links, there are lots of recorded lectures about various aspects of long COVID. And this one on the top, the one that ends in SILC, is an international one, and some of the recordings are in Portuguese. The last thing I wanted to mention before I close is throughout the pandemic, there have been pretty good consensus guidance statements issued by PM&R, which is the Physical Medicine and Rehab organization. And the name of the journal is PM&R, and it's posted on the American Academy of Physical Medicine and Rehab. I couldn't figure out how to get a short link, but if you go to this link, you come to the section in their journal that is specific consensus guidance that covers probably, I think they may have 6 or 7 guidance documents that are very useful for understanding the presenting aspects of long COVID. So thank you very much for an opportunity to join in this great effort, and thank you for planning such a great conference. And if we can be of any help with education, please let us know at Bateman-Horne Center. But I just think the more we try to teach each other, the better we'll be, and the knowledge is growing rapidly. So good luck, and thank you so much.